Hope you all are doing great. So let's continue with our series of green top guidelines. And today guideline is management of gestational trophoblastic disease. This is guideline number 38, GTG38, and it was published on September 2020. So executive summary of every guideline is very important. So starting with the question, how do molar pregnancies they present to the clinicians? Clinicians they should be aware of the symptoms and signs of molar pregnancy. The most common presentation is irregular vaginal bleeding, a positive pregnancy test, and supporting the ultrasonographic evidence. Less common presentation of molar pregnancy includes hyperemesis, excessive uterine enlargement, hyperthyroidism, and early onset preeclampsia and abdominal distension due to thicker lutein cyst. And very rarely, women they can present with the hemoptysis or seizures due to the metastatic disease affecting the lungs or the brain. How are molar pregnancy is diagnosed? The definitive diagnosis of molar pregnancy is made by histological examination. Removal of a molar pregnancy. What is the best method for the removal of the molar pregnancy? Suction curettage is the method of choice for the removal of complete molar pregnancies. Ultrasonographic or ultrasound guidance during the removal and curettage they may be of the use to minimize the chances of perforation and to ensure that as much tissue as possible is removed. Suction curettage is a method of choice for the removal of the partial molar pregnancies, except when the size of the fetal parts deters the use of the suction curettage and the medical removal they can be used. Anti-D prophylaxis is recommended following removal of a molar pregnancy. Is it safe to prepare the cervix prior to the surgical removal? Preparation of cervix immediately prior to the uterine removal is safe. Can oxytocic infusion be used during the surgical removal? Excessive vaginal bleeding they can be associated with surgical management of the molar pregnancies, and the involvement of an experienced clinician is advised. The use of oxytocic infusion prior to completion of the removal is not recommended. If a woman is experiencing significant hemorrhage prior to or during the removal, surgical removal should be expedited and the need for the oxytocic infusion weighted up against the risk of the tissue embolization. Is in what circumstances should a repeat surgical removal be indicated and what is the timing? There is almost always a role of the urgent surgical management for the women who is experiencing heavy or persistent vaginal bleeding causing the acute hemodynamic compromise, particularly in the presence of a retained pregnancy tissue on ultrasound. Outside the context of acute compromise, there should be consultation with the relevant GTG referral center before performing the surgical management for the second line or the second time in the same pregnancy. Histological examination of a pregnancy tissue in the diagnosis of the GTGD. Should pregnancy tissue from all miscarriages be examined histologically? The histological assessment of the material obtained from the medical or surgical management of all the miscarriages is recommended to exclude the trophoblastic neoplasia if no fetal parts are identified at any stage of the pregnancy. Women who receive care for miscarriage, they should be recommended to do a urinary pregnancy test 3 weeks after miscarriage. Should pregnancy tissue be sent for examination after abortion? There is no need to routinely send pregnancy tissue for the histological examination following the therapeutic abortion, provided that the fetal parts have been identified at the time of the surgical abortion or on the prior ultrasonographic examination. Women who undergo the medical abortion, they should be recommended to do a urinary pregnancy test 3 weeks after the procedure. How should women with an elevated human chorionic gonadotrophin after a possible pregnancy even be managed? The referral to a GTD center should be considered for all the women with the persistently elevated human chorionic gonadotrophin, either after an ectopic pregnancy has been excluded or after the two consecutive treatments with methotrexate for a pregnancy of unknown location. Which women they should be investigated for the GTN after a non-molar pregnancy? Any women who develop the persistent vaginal bleeding after a pregnancy, event is at risk of having the GTN, a urine HCG test they should be performed in all the cases of the persistent or irregular vaginal bleeding lasting more than 8 weeks after a pregnancy event, and symptoms from the metastatic disease such as the dyspnea and the hemoptysis or new onset of the seizures or the paralysis, they can occur very rarely. Biopsy of secondary deposits in the vagina, they can cause the major hemorrhage, is not recommended. How should suspected ectopic molar pregnancy in the women be managed? The cases of the women with the ectopic pregnancy suspected to be in the molar nature, they should be managed as any other case of the ectopic pregnancy. If there is a local tissue diagnosis of the ectopic molar pregnancy, the tissue they should be sent to a center with the appropriate expertise for the pathological review. How is the twin pregnancy of a viable fetus and the pre-exumptive coexistent molar pregnancy be managed? The women diagnosed with a combined molar pregnancy and a viable twin, or where there is a diagnostic doubt, should be referred to a regional fetal medicine center and GTD center. In this situation of a twin pregnancy where there is one viable fetus and the other pregnancy is molar, the women, they should be counseled about the potential increased risk of the perinatal morbidity and the outcome of the GTN. The prenatal invasive testing for the fetal karyotype, they should be considered in case where it is unclear if the pregnancy is a complete mole with a coexisting normal twin or a possible singleton partial molar pregnancy. Prenatal invasive testing for the fetal karyotype, they should also be considered in the case of abnormal placenta such as suspected mesenchymal hyperplasia of the placenta. How should a placental site trophoblastic tumor or the epithelioid trophoblastic tumor be managed? All women with the placental site trophoblastic tissue tumor or the epithelioid trophoblastic tumor ETT, they should be registered with and cared for the within a GTT center. How should a placental site nodule or atypical placental site nodule be managed? Women with an atypical placental side nodule or when where the local pathology is uncertain, they should have their histological reviewed centrally. All women with atypical PSN will then be called up for the central review to discuss the existing data and perform the staging investigations and to determine further management. Women with the typical PSN, they do not currently require the further investigation or review. Which women they should be registered at GTD center? All women diagnosed with GTD, they should be provided with the written information about the condition and the need for the referral for the follow-up by a GTD center, they should be explained. Clinician, they should be aware that the outcome for the women with the GTN and GTD are better with the ongoing care for the GTD center. The registration of the affected women with a GTD center, they represents a minimum standard of care. Women with the following diagnosis, they should be registered and require follow-up as determined by the screening center: complete molar pregnancy, partial molar pregnancy, twin pregnancy with the complete or the partial molar pregnancy, limited macroscopic or the microscopic molar change suggesting the possible early complete or the partial molar pregnancy, choriocarcinoma, PSGT or ETT, and atypical PSN. What is the optimum follow-up following a diagnosis of GTD? For complete molar pregnancy, if the HCG they has reverted to the normal within the 56 days of the pregnancy event, then the follow-up will be for the 6 months from the date of the uterine removal. If HCG has not reverted to the normal within 56 days of the pregnancy event, then the follow-up will be for the 6 months for the normalization of the HCG levels. Follow-up for the partial molar pregnancy is concluded once the HCG has returned to normal on two samples at least 4 weeks apart. Women who have not received chemotherapy no longer need to have the HCG measured after any subsequent pregnancy event. What is the optimum treatment of the GTN? Women with the GTN, they may be treated with the single agent or multi-agent chemotherapy, and treatment used is based on the FIGO 2000 scoring system of GTN. Following the assessment of the treatment center, PSGT and ETT are now recognized as the variants of the GTN, and they may be treated with the surgery because they are less sensitive to the chemotherapy. What is the recommended interval between a complete or partial mole pregnancy and trying to conceive in the future? What is the monitoring of the women following a successful pregnancy after a previous molar pregnancy, and what is the outcome of a subsequent pregnancies? Women, they are advised not to conceive until their follow-up is complete, and women who undergo chemotherapy are advised not to conceive for 1 year after the completion of the treatment as precautionary measures. Women who have a pregnancy following a previous molar pregnancy and which has not required the treatment for the GTN, they do not need to send a post-pregnancy HCG sample, and histological examination of placental tissue from any normal pregnancy after a molar pregnancy is not indicated. What is the long-term outcome of the women treated for the GTN? The outlook for the women treated for the GTN is generally excellent, with an overall cure rate close to 100%, and future pregnancies, they are achieved in approximately 80% of the women following the treatment of the GTN with either the methotrexate alone or multi-agent chemotherapy. There is an increased risk of the premature menopause for the women treated with the combination after the chemotherapy. Women, especially those approaching the age of the 40, and they should be warned of the potential negative impact on the fertility, and particularly when they're treated with the high dose chemotherapy. What is the safe contraception following the treatment of the GTN, and what should it be commenced? When should it be commenced? It is important that the women who have had a removal of the molar pregnancy are advised not to become pregnant until they have completed their HCG follow-up, and advice on the contraception after molar pregnancy can be found in the Faculty of the Sexual and Reproductive Health Guidelines Executive Summary Contraception after the pregnancy. And is the use of, we'll do it later, okay? Is the use of the exogenous estrogen and other fertility drugs safe for the women undergoing the assisted reproductive treatment after a molar pregnancy? The use of the exogenous estrogen and other fertility drugs, they may be used once HCG levels they have returned to the normal. Is the hormonal replacement therapy safe for the women to use after GTN? Hormonal replacement therapy, they may be used once HCG levels they have returned to the normal. Impact of the diagnosis on the women and their families. GTN centers, they now provide the individualized support to the women and their families throughout their GTD journey, and though the dedicated GTD nurse specialist and the advisors who can be assessed either through the attending a GTD center or via the phone or both. Online support groups, they are available, and molarpregnancy.co.uk, and alongside the regular drop-in sports groups at the Charching, the Cross Hospitals, London, and the Western Park Hospital, Sheffield, and further information available for each center. Definition. So let's start with the definition. Gestational trophoblastic disease, the GTD, comprise a group of the disorders spanning the pre-malignant conditions of the complete and partial molar pregnancies, also known as the hydatiform moles, and through to the malignant conditions of the invasive mole, choriocarcinoma, and the very rare placental site trophoblastic tumor, PSTT, and the epithelioid trophoblastic tumor, ETT. The malignant potential of the atypical placental site nodules, they remains unclear. If there is any evidence of the persistence of the GTD after the primary treatment, the most common defined as a persistent elevation of the HCG or the human chorionic the condition is referred to as the gestational trophoblastic neoplasia, GTN, and the diagnosis of GTN, they does not require histological confirmation. The diagnosis of a complete mole, partial mole, atypical PSN and PSTT, ETT, they does require the histological confirmation. So, purpose and scope, we are leaving it, and introduction to the background epidemiology. The molar pregnancies, they can be subdivided into a complete and a partial molar pregnancy based on the genetic and histopathological features, and complete molar pregnancies, they are diploid and androgenic in the origin and with no evidence of the fetal tissue. Complete molar pregnancy, usually 75 to 80%, they arise as a consequence of the duplication of the single sperm following the fertilization of an empty ovum, and some complete moles, 20-25%, they can arise after the dispermic fertilization of an empty ovum. And partial molar pregnancies, they are usually 90% diploid in origin with two sets of the paternal haploid chromosomes, and on one set of the maternal haploid chromosome. Partial molar pregnancies, they occur in almost all cases and following the dispermic fertilization of an ovum, and occasionally the molar pregnancies represent the tetraploid or the mosaic conceptions, and in a partial mole there is usually evidence of a fetus. or the fetal red blood cells, and not all tripolide or the tetrapolide pregnancies are partial moles. For the diagnosis of the partial mole, there must be a pathological evidence of the trophoblastic hyperplasia. GTD, hereditary mole, invasive mole, choriocarcinoma, PSTT is an uncommon occurrence in the UK with a calculated incidence of 1 in 714 live births, and there is evidence of the ethnic variations and the incidence of the GTD in the UK. And with the women from the Asia have the higher incidence compared with the non-Asian women, 1 in 387 versus 1 in 752 live births, and women aged less than 15. The incidence of GTD is associated with the age as the conception being higher in the extremes of the ages, women aged less than 15 years, 1 in 500 pregnancy, and women aged more than 50 years, 1 in 8 pregnancies. However, these figures may underrepresent the true incidence of the disease because of the problem with the reporting, particularly in regard to the partial moles and GT, and they may develop after a molar pregnancy and non-molar pregnancy or a live birth. The incidence after a live birth is estimated at the 1 in 50,000 on average. A consultant obstetrician and the gynecologist, they may only lead with one new case after 2 years. In the UK, there exists an effective registration and treatment programs. The programs has a cure rate of the 98 to 100% and a chemotherapy rate of 0.5 to 1% for the GAT and after the partial mole pregnancy, and 13 to 16% after complete mole pregnancy. Clinicians, they should be aware that the outcome from the women with the GT and GTD, they are the better with the ongoing management of the GTD centers, and the registration of the affected women with the GTD center, they represent a minimal standard of the care. Identification and assessment of the evidence. Okay, we don't need to do it at this stage. So how do the molar pregnancy presents to the clinicians? The clinicians, they should be aware of the symptoms and the signs of the molar pregnancies. The most common presentation is irregular bleeding, a positive pregnancy test, and the supporting ultrasonography evidence. The less common presentations of the molar pregnancy, they should include the hyperemesis, excessive uterine enlargement, and hypothyroidism, early onset preeclampsia, and the abdominal distension due to the thecal uterine cyst, and very rarely the women, they can present with the hemoptysis or the schisis due to the metastatic disease affecting the lungs or the brain. Vaginal bleeding, they remains the most common presenting symptoms of the molar pregnancy and is associated with approximately 60% of the presentation, and these symptoms, they has not changed despite a reductions in the gestation and the presentations from the 11 to 10 weeks between 1996 to 2006, and the percentage of the women with presenting with the abnormal ultrasonography test as the only presenting features increased from the 1% to 12% over the same time period. The use of the ultrasound in the early pregnancy, they has led to the earlier diagnosis of a molar pregnancy, and they there is a reduction in the mean gestation and the presentation from 16 weeks of the gestation from 1965 to 1975 to 12 weeks of the gestation between 1980 and 1993. There has been a future reduction in the gestational age at the diagnosis to the 9 weeks of the gestation between the 1994 and 2013. The majority of the histological proven non-molar pregnancies, they are associated with an ultrasound diagnosis of the delayed miscarriage or the an embryonic pregnancy. In one study, the pre-removal diagnosis of the molar pregnancy increases with the gestation age. 35 to 40% correctly identified before the 14 weeks of the gestation increased to the 60% after the 14 weeks of the gestation. Further study, they reported that the ultrasonographic examination, they correctly identified 56% of the molar pregnancies in the women with the suspected miscarriage, and when the pregnancy tissue, they was routinely examined after the surgical removal, the incidence of the molar pregnancy and atypical PSNs unrecognized prior to the removal was 2.7%. The ultrasound, the features is suggestive of a complete molar pregnancy include a polypoid mass between the 5 and 7 weeks of the gestation and thickened cystic appearance of the villus tissue after the 8 weeks of the gestation with a non-identifiable gestational sac. Partial molar pregnancies, they are associated with an enlarged placenta and cystic changes within the decidual reactions in association with the either an empty sacs or a delayed miscarriage. Using these criteria, a reasonable sensitivity for the complete mole in the 95% and 20% for the partial mole. The positive predictive value is low for the both complete 40% and partial 22%. A review of the ultrasound features of the partial and complete molar pregnancies, they found the ultrasound diagnosis of a partial molar pregnancy and to be more subtle reporting the findings of the multiple soft markers and including the cystic spaces in the placenta and the ratio of the transfers to the anterior posterior dimensions of the gestational sac greater than the 1 ratio 1.5. These features they may be of the help in the diagnosis of a partial molar pregnancy using these extra criteria. 41.4% of the partial molar pregnancy are correctly diagnosed prior to the removal compared with the 86.4% of complete molar pregnancy. A study of the women they presenting to an early pregnancy unit they reporting the ultrasonography correctly identified 88.2% of a complete molar pregnancy and 56% of the partial molar pregnancy. The estimate of the SAG, the levels they may be of the value in diagnosis molar pregnancy in a small study of the 51 suspected cases of the molar pregnancy. SAG, the levels they were significantly higher for both the complete and the partial molar pregnancies. The rare presentations they include the hyperthyroidism and early onset preeclampsia or the abdominal distension due to the theca lutein cyst and very the women they can present with the hemoptysis and acute respiratory failure or the neurological symptoms such as the seizures likely to be due to the metastatic disease. How are the molar pregnancy diagnosed? And the definitive diagnosis of the molar pregnancy is made by the histological examination, and pathological features they consist with the diagnosis of the complete molar pregnancy includes the absence of the fetal tissues and extensive hydropic change to the villi and the excess trophoblast proliferations, and the features of a partial molar pregnancy includes the presence of a fetal tissue and the focal hydropic change to the villi and some excess trophoblastic proliferation and the ploidy status and the immunohistochemistry staining for the P57 paternally imprinted gene, and they may help in the distinguishing partial from the complete molar pregnancies. The removal of the molar pregnancy. What is the best method for the removal of the molar pregnancy? Suction curettage is the method of choice for the removal of a complete molar pregnancies, and the ultrasonography guidance during the removal of the curettage they may be used or to the minimize the chance of the perforations and to ensure that as much tissue as possible is removed. Suction curettage is a method of choice for the removal of the partial molar pregnancies except when the size of the fetal parts they deters the use of the suction curettage, and that then medical removal they can be used. Anti-D prophylaxis is recommended following the removal of the molar pregnancy, and the complete molar pregnancies they are not associated with the fetal parts, and therefore the suction removal is the method of the choice for the uterine removal in irrespective of the uterine size, and the medical removal of the complete molar pregnancy they should be avoided if the possible irrespective of the agent used. In review of 4247 women with the GTD, the risk of developing the GTN and requiring the chemo therapy was 16 folds higher when the medical methods of the removal they were used compared with the surgical removal. And in addition there is a theoretical concerns both by the clinical experience for the routine use of the potent oxytoxic agents because of the potential to embolize and disseminate the trophoblastic tissue through the venous system and leading to the adult respiratory distress syndrome similar in presentation to the amniotic fluid embolism. For twin pregnancies, when there is a non-molar pregnancy alongside a molar pregnancy and the women they has decided to termination of the pregnancy or there has been demise of the coexistent twin, the size of the fetal parts they deters the use of the suction curettage medical removal they can be used. There is a high rate of the incomplete removal with the medical method, and the risk of this increasing the need for the treatment of the GTN in 13 to 16% with the complete molar pregnancies and the 0.5 to 1% with the partial molar pregnancy. A review of the literature they follow published evidence examining the use of the ultrasound at the time of the uterine removal of the GTN. There is a consensus view, however, this may be the preferred surgical option, and women who have an unrecognized molar pregnancy and undergo the medical or the clinical abortion of the pregnancy are at the increased risk of the life-threatening complications of the GTN and require the more surgical intervention, the chemotherapy. The poor vascularization of the chorionic villi and the absence of the D antigen by the trophoblast and cells it means that the anti-D prophylaxis is not required for the complete molar pregnancies. However, it is required for the partial molar pregnancies. Confirmation of the diagnosis of the complete molar pregnancy they may not occur for the some time after the removal, and which could delay the administration of the NTD. And if the diagnosis of the complete molar pregnancy they cannot be established within the 72 hours, NTD prophylaxis they can be administered for the practical reasons. It is safe to prepare the cervix prior to the surgical removal. Preparation of the cervix immediately prior to the uterine removal is safe, and wrapping of the cervix with either the physical dilator or the prostaglandin prior to the uterine removal is not associated with an increased risk of the developing GTN. In a case control study of the 219 patients, there was no evidence that the wrapping of the cervix prior to the uterine removal is linked to a high risk of the needed chemotherapy. Can oxytocin infusion be used during the surgical removal? And the excessive vaginal bleeding, they can be associated with the surgical management of the molar pregnancy, and the involvement of an experienced clinician is advised, and the use of the oxytocin infusion prior to the completion of the removal is not recommended. If the woman is experiences the significant hemorrhage prior to or during the removals, the surgical removal, they should be expedited, and the need for the oxytocin infusion they weigh up against the risk of the tissue embolization. Excessive vaginal bleeding, they can be associated with the surgical management of the molar pregnancy, and there is a theoretical concern over the routine use of the oxytocin agents, and including the ergometrin and the misoprostol, and because of the potential to embolize and disseminate trophoblastic tissue through the venous system. This is known to occur in the normal pregnancy, and especially when the uterine activity is increased, such as with the placental abruption. The contractions of the myometrium, they may force the tissue into the venous space at the site of the placental bed, and the dissemination of this tissue, they may lead to the profound deterioration in the patient with the embolic and the metastatic disease occurring into the lungs. In the event of the life-threatening hemorrhage or ongoing bleeding, oxytocin infusion, they may be used. In what circumstances there should be a repeat surgical removal be indicated, or what is the timing? There is almost always a rule for the urgent surgical management for the women who is experiencing the heavy or the persistent vaginal bleeding and the causing the acute hemodynamic compromise, and particularly in the presence of the retained placenta pregnancy tissue on the ultrasound. Outside the context of the acute compromise, there should be the consultation with the relevant GTD referral and center before the performing the surgical management for the second time in the same pregnancy. The woman with the persistent heavy vaginal bleeding and the evidence of the retained pregnancy tissue on the ultrasonographic examination, they may need a repeat surgical removal, and this remain true with a woman has had a prior surgical removal for the suspected GTD, and expediting surgical management in the case of the acute hemodynamic compromise is the priority, and delay they can be harmful, and consideration they should be given to the balloon tamponade and to the uterine artery embolization to reduce the risk of the hysterectomy for the women who wish to preserve the fertility. Embolization will not always stop the bleeding, and but will permit the management of the blood loss, and bleeding from the vaginal metastasis, it can be reduced by the compression from a vaginal bag. There are several cases, say series they have found there may be a role of the secondary removal in the selected cases when the HCG is less than 5,000 units. A prospective phase 2 trial of a second removal of the GTN, they reported 40% of the women avoided the chemotherapy as a consequence of the undergoing the second removal with the low complication rates. In 3 out of 34 cases in which the primary treatment failed, the histological findings on the second removal, they were significantly different, PSTT, when compared the initial diagnosis, the molar pregnancy. And histological examination of pregnancy tissue in the diagnosis of the GTD, they showed the pregnancy tissue, therefore all the miscarriages be examined. The histological assessment of material obtained from the medical or the surgical management of all the miscarriages is recommended to exclude the trophoblastic neoplasia if no fetal parts are identified at any stage of the pregnancy. And the women who receive the care for the miscarriage, they should be recommended to do a pregnancy urinary pregnancy test 3 weeks after the miscarriage. As a GTD, they can be difficult to recognize at the time of the miscarriage. Is recommended that either all the material obtained from the medical or the surgical management of the miscarriage, they should be sent to the pathology, or if the tissue has been sent to the pathology, a pregnancy they test it should be carried out 3 weeks after the miscarriage. If this is still positive, the serum levels they should be tracked to ensure that the levels is the falling, and if not, and the ultrasound is arranged to look for the further pregnancy tissue, and all tissue they obtain in the situation they should be sent to the pathology, and the incidence of the GTD unrecognized prior to the removal is 2.7%. Should the pregnancy tissue they be sent for the examination of the abortion, there is no need to routinely send the pregnancy tissue for the histological examination following the therapeutic abortion, provided that the fetal parts they have been identified at the time of the surgical abortion or prior ultrasound examination. The women they should be who undergo the medical abortion, they should be recommended to do a pregnancy test 3 weeks after the procedure. And the rate is estimated to be 1 in 20,000. And however, the risk of the failure of the diagnosis GTD at the time of the abortion, they lead to the evidence outcome, and with a significant high risk of the life-threatening complication, the surgical intervention, and including the hysterectomy and the medical or the multi-agent chemotherapy. How should the women they with an elevated HCG after a possible pregnancy even be managed? Referral to the GTD, they center they should be considered for all the women with the persistently elevated HCG, either after an ectopic pregnancy has been excluded or after the 2 consecutive treatment with the methotrexate or for the pregnancy of the unknown location. GTD they can develop after any pregnancy event or in the failure to the treat the GTN. They can be fatal GTN. They requires a more intensive chemotherapy than the treatment of a pregnancy of unknown location. Very rarely, some women they will have the familial raised HCG and the HCG levels between the 10 to 200, and these the low levels of the HCG elevations they are also associated with a malignant female germ cell tumor and any epithelial cancer, including the bladder, breast, lung, gastric, and the colorectal cancers. And low levels of the HCG elevation they can also be caused by the presence of the pituitary HCG on the presence of the human anti-mouse antibodies. And HCG glycoproteins they can represent in the many forms and in both the serum and the urine, including the intact HCG, the free HCGB, beta subunits, they nicked HCG and HCGB core fragment. Molar pregnancies and GTN they can produce all the variants of the HCG, and most commercial HCG assay for the routine laboratory they use for do not measure all the HCG variants. And the 3 UK GTD centers they are specialized in the houses HCG assay to detect all the forms of the HCG. Which women they should be investigated for the GTN after a non-molar pregnancy? Any women who develop the persistent vaginal bleeding after the pregnancy event is the risk of having the GTN. And a urine HCG test they should be performed in all the cases of the persistent or irregular vaginal bleeding. And symptoms they from the metastatic disease such as the dyspnea and the hemoptysis or a new onset of the seizures or the paralysis they can occur very rarely. Biopsy of secondary deposits in the vagina they can cause a major hemorrhage and is not recommended. GTN they can develop after the miscarriage, therapeutic absorption, and the term pregnancies. Choriocarcinoma is estimated to occur after the approximately 1 in 50,000 pregnancies, and it is uncommon for the GTN to develop in the women who have had a normal HCG urine or the serum levels within the 8 weeks of the removal of a molar pregnancy. The several cases, the series they have shown the vaginal bleeding is most common persisting system of symptom of the GTN, diagnosing after the miscarriage and therapeutic abortions or the postpartum. The prognosis for a women with the GTN after a non-molar pregnancy, they may be the worst owing to a delay in the diagnosis or the advanced disease such as the liver or the central nervous system disease at the presentation. How should suspected ectopic molar pregnancy in the women be managed? The cases of the women with the ectopic pregnancy suspected to be molar in the nature, they should be managed as any case cause of the ectopic pregnancy. And if there is a local tissue diagnosis of the ectopic molar pregnancy, the tissue they should be sent to a center with the appropriate expertise for the pathological review. Ectopic molar pregnancy is a very rare event, and symptoms and the signs are the same as any other ectopic pregnancy, and the histopathological features of any early complete ectopic molar pregnancy they can be confused with the choriocarcinoma. How is twin pregnancy of a viable tissue or the viable fetus and the presumptive coexistent molar pregnancy be managed? The women that are diagnosed with a combined molar pregnancy and with a viable twin, uh, or where there is a diagnostic doubt, and they should be referred to as a regional fetal medicine center and the GTD center. In the situation of a twin pregnancy where there is one viable fetus and the other pregnancy is molar, and the women they should be counseled about the potential increased risk of the perinatal morbidity and the outcomes of the GTN. The prenatal invasive testing for the fetal karyotype they should be considered in the cases where it is unclear if the pregnancy is a complete mole with a coexisting normal twin or a possible singleton partial molar pregnancies, and the prenatal invasive testing for the fetal karyotype they should also be considered in the case of the abnormal placenta, such as suspected mesenchymal hyperplasia of the placenta. And there is an increased risk of the early fetal loss, 40% in the premature birth, 36% in the twin pregnancy of a viable fetus and the coexisting molar pregnancy. The incidence of the preeclampsia is variable, with the rate as high as 20% reported. However, in the large UK series, the incidence was only 4% and there was no maternal death. In the same UK series, there was no increase in the risk of the developing GTN after such a twin pregnancy, and the outcome after the chemotherapy was unaffected. Analysis of further 153 UK series confirmed the earlier experience with a slight higher rate of the babies surviving, 51%, and no maternal death and no increase in the need for the chemotherapy, 50% in the women who gave birth after the 26 weeks of the gestation. Some women they may wish to continue with their pregnancy. Increasing monitoring for the preeclampsia and the fetal and the maternal well-being during such ongoing pregnancy is sensible. Histological examination of the placenta is recommended, and all confirmed cases of the GTD registered with the GTD center. How should a placental site trophoblast tumor or the epithelioid trophoblastic tumor be managed? And all the women with the PSTT and ETT, they should be registered with the care for within a GTT center. PTT and ETT, they are rare forms of the GTT diagnosed by the histological examination of the retained pregnancy tissue, and their presentations and the behavior are the different and less predictable. Hysterectomy is curative in many cases with the localized disease. In women with the long-term periods such as the antecedent pregnancy and or with the distant or the extensive metastatic disease and intensive chemotherapy, they play a major role. How should a placental side nodule or the atypical placental side nodule they be managed? The women with an atypical PSN or where the local pathology is uncertain, they should have their histological review centrally, or women with the atypical PSN will then be called for the central review to discuss the existing data and perform staging investigation and to determine the further management. Women with the typical PSN, they do not currently require the future investigations or review. PSNs have been for many years regarded as a benign finding of the little clinical significance. There has been reported of the PSN with or without atypical features, and which has either been admixed with the PSTT or ETT, or that the subsequently progressed over the time of the PSTTs or ETTs. This link to the cancer appears strongest with the atypical PSNs and may occurs in 10 to 15% of the women. The condition they often presents with the vaginal bleeding resulting in the endometrial biopsy, or because of the hysteroscopic biopsy performed for other reasons. And those women who have completed their families, they may wish to continue a hysterectomy in the absence of the metastatic disease. Women who desire more children, they require careful counseling and the future testing. What women they should be registered at the GTT center? Which women they should be registered at the GTT centers? All women diagnosed with the GTT, they should be provided with the written information about the conditions and the need for the referral for the follow-up via a GTT centers. They should be explained. Clinician, they should be aware that the outcome of the women with the GTT or GTN are better with the ongoing care from the GTT centers. The registrations of the affected women with the GTT center, they represents minimum standards of the care. The women with the following diagnosis, they should be registered and require follow-up as determined by the screening centers: and complete molar pregnancy, partial molar pregnancy, and twin pregnancy with the complete or the partial molar pregnancy. Limited microscopic or macroscopic molar changes is suggesting the possible early complete or the partial molar pregnancy, choriocarcinoma, PSTT or ETT, and atypical PSN. The overall risk for requiring the chemotherapy for the GTN is 13 to 16% for the complete molar pregnancy and 0.5 to 1% for the partial molar pregnancy. Hence, the need for the registration and follow-up, which consists of a serial HCG levels and either in the blood in the urine. Choriocarcinoma, if not treated early, is potentially lethal and requires the immediate registration, specialist assessment and treatment. PSTTs and ETTs, they are rare and the unpredictable tumors that need specialist assessment and treatment. Atypical PSNs, they may transform into a PSTTs and ETT as so. Although women with this condition, they should be registered. What is the optimum follow-up following a diagnosis of GTT? For complete molar pregnancy, if the HCG has reverted to the normal within 56 days of the pregnancy, even then follow-up will be for 6 months for the date of the uterine removal. And if the HCG has not reverted to the normal within 56 days of the pregnancy even, then follow-up will be for 6 months for the normalization from the normalization of the HCG levels. Follow-up for the partial molar pregnancies concluded once HCG has returned to a normal on the two samples at least 4 weeks apart. Women who have not received chemotherapy no longer need to have the HCG measures after any subsequent pregnancy event. In several large cases, they have shown that once the HCG reverts to the normal, the possibility of GTN development is very low. The incidence of the GTT subsequent pregnancy event is very low, and in women who have not received chemotherapy for a paramolar pregnancies. What is the optimum treatment for the GTN? The women with the GTN, they may be treated with the single agent or the multi-agent chemotherapy, and treatment used is based on the International Federation of the Gynecology and the Obstetrics, the FIGO 2000 scoring system for the GTN. Following the assessment of at the treatment of the center, PSGT and ATT, they are now recognized as a variants of the GTN, and they may be treated with the surgery because they are less sensitive to the chemotherapy. The women with the assessed before the chemotherapy using the FIGO 2000 scoring, the women with the score of the 6 or the less or are at the low risk, and with the treated with the single agent intramuscular methotrexate alternating the daily with the folinic acid for the 1 week and followed by the 6-week rest. And the women with the scores of the 7 or the greater, they have the higher risk and are needed with the intravenous multi-agent chemotherapy, and with includes the combination of the methotrexate and the dactinomycins and the etoposide and the cyclophosphamide and the vincristines. Treatment is continued in all the cases until the HCG levels has returned to the normal, and then for a further 6 consecutive weeks. The women they suspected of the choriocarcinoma requires a more extensive investigations in the specialist centers, including the computed tomography of the chest and the abdomen, or the MRI of the head and the pelvis, or with the contrast with the in addition to the serum HCG and the Doppler ultrasonography for the pelvis. And women with a score of 13 or greater is now recognized to have a high risk of the early death within 4 weeks, and often due to the bleeding into the organs, or the late death due to the multi-drug resistant disease. The cure rate of the women with the score of the 6 or less is almost 100%, and with the rate of the women with the score of the 7 or greater is 94%. Rarely women with the multi-relapse disease will require the high dose of chemotherapy with the stem or all cell recovery. So what is the FIGO scoring system? It includes the age, antecedent pregnancy, and the interval month from end of the index of the pregnancy to treatment, and the pre-treatment serum HCG, international units per liter, and the large tumor size including the uterus and centimeter, and size of the metastasis and number of metastases, and the previous failed chemotherapy. The score is given from 0, 1, 2 and 4, and if the age is the 0 score includes if the age is less than 40, and there is a molar pregnancy, antecedent pregnancy is mole, and the interval months from the end of the index pregnancy to treatment is less than 4, and pre-treatment serum HCG is less than 10/3, and large tumor size including the uterus less than 3 centimeters, size of metastasis in lung, and number of metastases is nil, and previous failed chemotherapy is nil. It is given when the age is more than 40 and there is abortion, and the interval month is between 4 to less than 7, and when the serum beta HCG levels from 10/3 to less than 10/4, and largest tumor size is 3 to less than 5 centimeter, and the size of the metastasis is in spleen or the kidney, and the number of the metastasis is 1 to 4. It is given when the antecedent pregnancy is birth, and when the interval month is 7 to less than 13, and the beta HCG level is 10 par days to 4 to less than 5, and when there is a largest tumor size more than 5 centimeter, and there is a gastrointestinal size of the metastasis, and the number of metastases from 5 to 8, and there is a single drug failed. And it is given for when the interval month is more than 13 months and the HCG levels are more than 10 to raise 5 and the meds are in the liver or the brain and the number of meds are more than 8 and 2 or more drugs have been failed. So PSG and ETT, they are the rarest form of the GTN, comprising about the 0.2% of all the GTD, and they tend to produce less HCG and are confined to the uterus for the longer and more often. They involve the lymphatic and are more chemo resistance than the other form of the GTN, and for these reasons they are not managed according to the figure score, and evidence they shows that the most important prognostic factor for the adverse outcome in the interval to the presentations from the last known and the presumed causative pregnancy, an interval of the more than 48 months previously have been associated with the 100% death rate regardless of the stage and despite initial favorable and the responses to the treatment. And in contrast, women presenting within 48 months are nearly all long-term survivors, and more recent series who have more intensive treatment, they were given to PS and EDT patients with a long interval from their causative patient reported the improved survival, but still over the 50% they died in this group. Stage 4 disease has now emerged as an independent poor prognostic factor, and the surgery they play a very important role in the management of the PSTT and ETT, which is tailored around the stage and the risk factors. And thus for the women with the stage 1 disease, the hysterectomy is the mainstay of the management, and the intensive platinum based combination agent chemotherapy is only required if the interval is more than 48 months, and rarely the women with the multi-relapsed disease will require the high dose chemotherapy with the stem cell recovery or the treatment with the immunotherapy who have been improved by the NHS England for the GTN cases in this situation. So what is the recommended interval between a complete or partial mode pregnancy and trying to conceive in the future, and what is the monitoring of the woman following a successful pregnancy after a previous mode pregnancy, and what is the outcome of the subsequent pregnancies? The women, they are advised not to conceive until their follow-up is complete, and women who undergo the chemotherapy are advised not to conceive for 1 year after the completion of the treatment as a precautionary measures. And the women who have a pregnancy following a previous molar pregnancy which has not required the treatment of the GTN do not need to send the post pregnancy HCG sample and histological examination of the placental tissue from any normal pregnancy after a molar pregnancy is not indicated. The risk of the future molar pregnancy is low, approximately 1%, and is associated more with the complete than the partial molar pregnancy. And women who become the pregnant following a molar pregnancy are not at the increased risk of the maternal complication. However, women exposed to a molar pregnancy prior to the index birth with an almost 25% increased risk of the preterm birth, and whereas the woman with at least one birth between the molar pregnancy and the index birth were at increased risk of the large for the gestational age birth and the stillbirth. In a study of 230 women who conceived within the 12 months of the completing the chemotherapy, there was an increased risk of the miscarriage and higher rate of the abortion in the women who received the multi-agent chemotherapy compared with the women who received the single agent chemotherapy. And the increased risk of the abortion, they may in the part reflects an increase in the concern relating to the heterogeneity after the receiving the multi-agent chemotherapy. The rate of the congenital abnormality there was low irrespective of the type of the chemotherapy used, and the rate of the stillbirth was elevated compared with the normal population. However, in another UK study of the 241 treated patients who had a pregnancy within the 12 months of the pregnancy chemotherapy, there was no longer increased risk of the miscarriage, ectopic of pregnancy and second molar pregnancy or the stillbirth compared to the general UK population. There was no increase in the risk of the relapse in the women who conceived early compared to those who conceived after the 12 months of the 12 months. Now, what is the long-term outcome of the woman treated with the GTN? And the outlook for the woman treated for the GTN is generally excellent, and with an overall cure rate close to the 100%. And further pregnancies are achieved in approximately 80% of the women and the following treatment of the GTN with either the methotrexate along with the multi-agent chemotherapy. There is an increased risk of the premature menopause for the women treated with the combination agent and chemotherapy, and women, especially those approaching the age of the 40 years, they should be warned of the potential negative impact on the fertility, particularly when the treatment with the high dose chemotherapy. there. So what is the safe contraception following the treatment of the GTN, and what should be when should it be commenced? So it is important that the women who have had a removal of a molar pregnancy, they are advised not to become the pregnant until they have the completed their SHG follow-up. And advice on the contraception after a molar pregnancy, they can be found in the faculty of the sexual and reproductive health. And elevated SHG during the follow-up day period, they may indicate the reoccurrence. Pregnancy is best avoided during the follow-up period until the success of the treatment has been established, and please refer to the FSH guidelines for the further update. And is the use of the exogenous estrogen and the other fertility drugs safe for the women undergoing the assisted productive treatment of after a molar pregnancy? The use of the exogenous estrogen and other fertility drugs, they may be used once SHG levels have been returned to the normal. And there appears to be no evidence of the risk that the use of the exogenous estrogens and the fertility drugs affect the outcome of the GTN. Is the hormonal replacement therapy safe for the women used for the GTD? The hormonal replacement therapy, they may be used once SHG levels have been returned to the normal. And there appears to have been no evidence of use of the hormonal replacement therapy the affects the outcome of the GTN. So impact of the diagnosis on the women and their families. The GTD centers, they now provides individualized support to the women and their family throughout their GTD journey, and though the dedicated GTD nurse, their specialists and advisors there who can assess through the attending a GTD center or via phone or both. And online sports groups are available, and alongside the regular drop-in sports group at the caring cross Hospital London and the Weston Park Hospital and Chapel, and further information is available from each center. So GTD centers in the UK, these are the following GTD centers in the UK, and the address is given, and there is a recommendation for the future research, and the other audible topics are also here, and we don't need to do at this of the time. And so here we conclude our these guidelines. And yes, again, in the guidelines you have seen multiple times the classification of the evidence level and the weight of the recommendations. I have made a separate video for this, you can refer that. So I hope you like the video. Stay connected.